MCQs. To start with, a 45-year-old woman presents to your GP clinic for the review. A few months ago, she developed redness around the nose and cheeks and became worse after she drank alcohol. Recently, she was asked by one of the colleagues at work if she has alcohol problem because her appearance resembles that of excessive alcohol use. She drinks an average of 10 units of alcohol per week. Her facial appearance is shown in the figure. Which of the following is the most likely diagnosis? So the clue here is the distribution of the erythema. Erythema in the centrofacial area is very much particular for the rosacea. So rosacea present with the centrofacial distribution area that involve your cheeks, chin, nose, and sometimes forehead also. Alcohol is not the cause of rosacea, but it's definitely a triggering factor. So the diagnosis here is the acne rosacea. Here is the erythematous butterfly distribution. Additionally, chin is also involved. There are different types of rosacea. One is the vascular rosacea, which presents as a form of erythema, edema, and telangiectasia. Next is the inflammatory rosacea that presents as papule, pustules, but no comedones. That differentiates it from the typical acne, that no comedones are present in the pustular lesions of the rosacea. And the treatment is antibiotic. It is more common in the middle-aged females and it is triggered by the cold climates. There are some patient complaints of itch, hot, burn, sting sensation, and the patient report they are increasingly irritated by the topical products because there are so much erythema and edema. Their topical products are irritating for them. The very important clue for the rosacea recognition in the pictures or in the scenario is that periorbital and the perioral and periorbital areas are spared. The etiology of rosacea is unknown. Alcohol is not the cause, but it triggers the rosacea in flushing and worsens the symptom. Other triggering factors include hot and cold temperature, wind, hot drinks, caffeine, exercise, spicy food, emotions, topical products that irritate the skin and decrease the barrier, and medication that cause flushing. Anything or any trigger that cause increased vascularity of the skin is basically the triggering factor of the rosacea. Then comes symptoms of the rosacea. It can present with itching, burning, grittiness, or the foreign body sensation in the eye as well, and erythema and swelling of the eyelid. There can be a bulbous or rhinophymatous changes of the nose as well. The other option, seborrheic dermatitis, has a scaly predominantary features in a seborrheic distribution. Erysipelas is associated with the abrupt onset of erythematous butterfly rash, most commonly caused by the streptococcal pyogenes. Erysipelas has a very well demarcated border. It's more or less the same form of cellulitis, but the cellulitis has a vague distribution, irregular borders, but the erysipelas is very well demarcated. And another thing is that although the rash resembles that of SLE, the lack of sign and symptom favoring the SLE will have some of the systemic feature, any organ involvement or any other system involvement. It does not present with just a facial rash. Alcohol-related skin disease, general term, not a diagnosis. Rosacea worsens by the alcohol, but it is not caused by it, all as already discussed. The treatment of rosacea, if there is a mild erythema, the treatment is metronidazole gel in the form of 0.75% BD ointment or gel form, azelaic acid 15% gel once daily, ivermectin 1% cream once daily. While the rhinophyma, there is a hypertrophy of the nasal sebaceous gland in the older male when there is a history of rosacea. The treatment is with laser, Cevaxion, and isotretinoin. Well, third form of rosacea that we discussed later on was inflammation, papules, and pustules. It is treated with the antibiotics in the form of doxycycline and isotretinoin in the severe recalcitrant cases. Next comes a 23-year-old woman presents to your GP clinic with a rash on her back. The rash appeared 2 months ago with a 3 to 4 centimeter oval patch on her upper back that later was followed by the eruption of smaller spots and the occasional itch. This oval patch is very typical of the Herald patch. This is a clue for the Pityriasis rosea. And after Herald patch, after a couple of days, so there is a small eruption that is itchy. The spots are paler, they're surrounding the skin. Pallor is showing basically your hypopigmented lesion. So hypopigmented lesion with the Herald patch, it points toward the Pityriasis rosea. So next, she has tried tanning oils and salons where the rash persists. On examination, there are multiple 3 to 5 millimeter macules on the back distributed in the Christmas tree pattern. Christmas tree pattern is just a, you can say, straightforward term or clue for the Pityriasis rosea. It's basically the lesions follow the lines of cleavage of the skin. Therefore, they form the Christmas tree pattern. Which of the following is most likely diagnosis for a straightforward MCQ? Pityriasis rosea. Pityriasis means scaling. So whenever the word pityriasis is used, it indicates scales. So pityriasis rosea is a fine pink scale that is common skin condition otherwise healthy people, especially in the children and young adults, which is common thought to be a viral infection. Viral infection, the most common virus is HSV 6 and 7, but there are many other causes of pityriasis rosea. The eruption begins with a herald patch, which was shown in the scenario as the oval patch on the upper back. This is the most typical location of the herald patch, and that may be mistaken for the tinea. The rash is then followed by approximately 2 weeks interval of the development of multiple scaly salmon-colored macules, about 1 to 2 cm in size, oval in shape. The eruption is symmetrical and most commonly involve the chest, back, abdomen, and adjoining area of the neck and limbs. Lesions are not usually seen on the face, hand, and feet, and the ear are arranged along the line of creases as discussed earlier in the form of Christmas tree pattern, and sometimes they are itchy, not all the time. This is a typical herald patch. If you see just this one diagram, you can say it's a tinea because there is a well demarcated annular lesion with a central clearing, which is a very typical rash of tinea, and many of the times the pityriasis rosea initial lesion is treated as tinea, but later on, after a couple of weeks, there are macular eruption which clears that it is a pityriasis rosea, and the typical Christmas tree distribution is very typical for the pityriasis rosea. Pruritus is common in 25 to 75% of the patient with mild to moderate severity. Secondary eczematic changes can also occur. There can be accompanied systemic features in the form of headache, nausea, anorexia, chills, fever, and arthralgia sometimes. Sometimes there can be lymphadenopathy before the onset of rash as well. Patient needs to be treated symptomatically. Menthol is often effective for the mild itching. Moderately potent corticosteroids are used for more severe cases of itching. Exposure to sunlight may be effective in the alleviation of the itching as well as hastening the resolution of the rash. The condition resolves spontaneously. If you don't treat it, it's going to be resolved. It's a benign condition and resolution occurs in 6 to 8 week interval, but some lesion may persist for as long as 3 to 4 months. So first line is the symptomatic treatment and the second line is just wait and watch approach. With resolution of eruption, post-inflammatory pigmentation can be observed. Both hypopigmentation and hyperpigmentation can resolve in rash. Dark skinned people may experience hyperpigmentation that takes a few months to resolve. There are some drugs that cause PR like eruption. PR is basically pityriasis rosea. So the mnemonic is I know my ABC. I for isotretinoin and imatinib, no for K for ketotifen, M for metronidazole, metoprolol, and ABC for acetyl salicylic acid, arsenicals, barbiturate, bismuth, captopril, and clonidine. So by this easy mnemonic, you can remember all the drug that causes pityriasis rosea like lesions. Next comes 8-year-old boy is brought to the practice with a complaint of itchy lesions. Itchy lesions, as shown in the figure, he has recently prescribed cotrimoxazole. Which of the following could be the most likely diagnosis? So here you can see these are very much similar lesions to the herald patch of the pityriasis rosea, but you can't appreciate any macular lesion that was accompanying the herald patch. These are all the more or less same lesion with the annular distribution and the central clearing, all of different morphological pattern, different sizes. So this is typical lesion of the tinea. Tinea infection presents as a circular lesion with a central clearing and that's very itchy. The photograph show multiple round lesions of the different size on the face, chest, abdomen, and arm. The lesion are prominent circular edges with a central clearing. With itchiness, the history dermatophyte infection, which is a tinea, is very likely diagnosis. So tinea is dermatophyte fungus that cause any part of the skin. The typical rash of tinea has the following characteristic. It is annular. It has scaly and itchy surfaces and definitive edges and central clearing as it expands. So it is the very typical features of the tinea, that it's scaly, it's itchy, and it has definitive clear edge. Psoriasis is characterized by erythematous patches distributed in a symmetrical distribution. Should not be confused with the psoriasis. Psoriasis is very red or erythematous lesions in a symmetrical distribution, so that's definitely not psoriasis. A unique feature of psoriasis is the silvery scale of the patches that are absent here. Moreover, psoriatic lesions do not show central clearing. So psoriasis it has a very typical scales over it. There will be erythematous circular lesion overlying silvery scale. Contact dermatitis is itchy condition erythematous rash without central clearing. Allergic reaction to medication like cotrimoxazole, as mentioned in the scenario, can cause various clinical pictures including the itchy erythematous rash but without central clearings. Wheals or hive have the clear centers, but the appearance of lesion is different from the photograph and there is no scaling in the wheals. So by 2 or more 3 clues, you can just divert the scenario or you can make your answer. Tinea versicolor, Pityriasis versicolor presents with a hypo and hyperpigmented macules of the different size with a slight scaling and itching. There is no clear central clearing of the lesion. So a very important clue for the central clearing. It points towards the tinea. So all the most of the lesions and circular lesion or erythematous lesion do not clear with the central area clearing. This is another scenario of the similar tinea fasciae, which is involving the facial area. 15-year-old boy presents to the practice with the lesion showing in the following diagram. The lesion is itchy, so again the itchy skin condition, which is in the form of circular, which has the central clearing, so it's a clear-cut tinea, and the lesion is distributed on the face, so a tinea of the face. And this is the again same description as described previously. There is some description of the Pityriasis versicolor as well. Pityriasis versicolor, Tinea versicolor, it is an itchy condition of fungal infection which is caused by the Malassezia furfur. There is a well demarcated macular rash as shown in the figure. Macule is basically any lesion that is hypopigmented or hyperpigmented, means color change, and that is not palpable from the skin surrounding area. So it's a macule which is less than 1 centimeter. If the same lesion is greater than 1 centimeter, that is going to be patch. So non-palpable lesion which is well demarcated, hyper or hypopigmented or slightly itchy, that is your Pityriasis versicolor. It is most commonly seen in the trunk area as shown in this diagram. However, it may involve the whole trunk, neck and upper limbs. Tinea versicolor do not show the central clearing, so there is no central clearing. These are just the spreading macules. Next MCQ, which of the following parts of the nail is most commonly affected by the tinea unguum? Unguum is basically for the finger. So which of the following tinea involve the tinea fungus? So nail plate is basically the part of the nail that is more commonly affected by the tinea unguum. Tinea unguum is infection of the nail, fingernails or toenails caused by the dermatophytes, which is fungus. Generally, fungal infection of the nails is termed as onychomycosis, that is onychomycosis. Onychomycosis which are superficially caused by the dermatophytes is referred as tinea unguum. There are three distinct patterns, which is distal subungual, proximal subungual and wide superficial. Distal, on the basis of the location of the fingernail, there is a distal part of the nail plate that gradually spreads to entire the whole of the nail plate and also involves your cuticle. Cuticle is just the screen part of the nail that is forming the junction with the nail and the skin. So it's a cuticle area. It is caused by the trichophyton rubrum. Next is the proximal subungual. Subungual is also called by the trichophyton rubrum. It presents with a whitish, yellow and brownish discoloration of the nail starting from around the cuticle and spreading distally. Wide superficial is the most common, and this is caused by the mentagrophytes. You can remember it as it is the major portion of the onychomycosis. So major type is formed by the mentagrophytes. M for major, M for mentagrophytes. It is a dull white spot on the surface of the nail plate. The whole nail plate may eventually be involved in the white area, soft and scrape gently for obtain a sample. These were the types of the onychomycosis. Next comes 17-year-old boy presents to your practice with the lesion showing in the accompanying photograph. The lesion have failed to improve with the conventional therapy. Which of the following would be the most appropriate management? Clearly, this is a nodular cystic acne. There are multiple cysts that can be appreciated on the face, and there are different papules and pustules, and some of the common ones can also be appreciated. So this is a very severe acne that is not responding to the conventional therapy. Conventional therapy is the topical therapy or the antibiotic therapy. So very severe acne, when not responding to conventional therapy, your isotretinoin is going to be the best option. The photograph shows severe cystic acne with the scarring, and the systemic isotretinoid Recutane is the best treatment, last resort for the severe cystic acne with the scarring if conventional therapy fail. In this patient, no response to conventional therapy, systemic isotretinoin is the most appropriate treatment option. For mild papulopustular acne, you are going to give the topical retinoids or the benzoyl peroxide treatment. If it fails, then the topical clindamycin or erythromycin in the form of antibiotic. Then salicylic acid face wash can be given, or salicylic acid creams can be given for the mild truncal acne. For moderate to papulopustular acne, you have to straightforward give the oral and topical combination, like topical retinoid benzoyl peroxide, but oral rather than topical antibiotic should be used in the form of oral doxycycline, which is available in the form of tetracycline or minocycline, or topical oral erythromycin. Erythromycin is 250 mg to 500 mg twice daily. It is a choice for the pregnant women because tetracycline is teratogenic. T for tetracycline and T for teratogenic. So tetracycline is not given in the pregnancy. Teratogenic. So it's an absolute contraindication in pregnancy. So pregnancy, you are left with only one option, which is erythromycin or the topical treatments. For moderate to severe acne, the options are topical retinoids along with retinoid plus antibiotics sometimes in a start of treatment. If there is no improvement by the 6 weeks or the insufficient improvement by the 12 weeks, the antibiotics are changed or doses increased, but the treatment is going to be systemic for sure. Next, 45-year-old women presents to your clinic concerning about the solitary patch of the hair loss. There is a solitary patch of the hair loss. 5 into 6 centimeter on examination, scalp of the affected area is completely hairless. So there is no hair at all. But the normal appearing with no scarring inflammation, that is showing there is not scarring alopecia. So we are dealing with the non-scarring alopecia and their localized variety that is not diffused. Which of the following is the next step in the management? So definitely it's alopecia areata, which is a localized hair loss with no inflammation and no scarring. So for localized alopecia areata, your intradermal injection of triamcinolone is going to be a best option. If this patch is not very much large, like 5 to 6 centimeters is a large patch. If it is not large, topical treatment can be given, but the topical treatment are more effective if we give it potent steroid or the very potent steroid. This hydrocortisone is a mild steroid. It's not going to work for the alopecia areata. Unaffected scalp skin or the complete hair loss are suggestive of alopecia areata. It is used for the hair disorder characterized by one or more discrete area of the hair loss. Although hair loss can occur anywhere in the body, hair loss of the scalp and eyebrow and beard are the most commonly affected by the medical attention. And the pathophysiology, it's basically an autoimmune process. There is an arrest of hair of the anagen hair bulb leading to cessation of the hair growth but not destruction of the hair follicle. Therefore, your hair follicle is preserved, therefore no scarring is present in the alopecia areata. The etiology of this autoimmune is unknown, probably genetic factor. 20% has a positive family history of alopecia areata as well. The course of the disease is extremely variable. Hair growth may occur and the patches resolve spontaneously. So if you don't do anything to the patient, it's going to be resolved, but the time duration is so vast and the patient is very much afraid of this alopecia, so you have to treat that. However, the patches may remain unchanged or expand and coalesce to form the patches to result in the alopecia totalis that involve the whole of the scalp, and alopecia universalis that entire body is involved. So these are the two important terms. Universalis is like universal, involving whole of your body, and totalis is involving total scalp. With a single patch of hair loss, there is a 33% chance of the hair regrowth in 6 months. This chance will increase to 50% in about 12 months, but the 12 months is a longer duration, so you have to treat that patient for the patient satisfaction. This is a table showing different potency of the corticosteroids. Betamethasone dipropionate is basically very potent, and this is a good option for the alopecia areata. Potent is betamethasone dipropionate 0.05%, betamethasone valerate, methylprednisolone, mometasone, and triamcinolone acetonide. These are potent and very potent steroid for those with the extensive lesion greater than 50% of the scalp hair recurrence or the topical immunotherapy. It's a probably most effective first line treatment. A potent that is this one. A potent corticosteroid is applied to the scalp weekly basis to precipitate allergic contact dermatitis. The consequence is mild inflammatory reaction that is associated with the hair regrowth. So all you have to do is create the inflammation, because it's an inflammatory process. Whenever there is a start of inflammation, then there is a regrowth of the hair. For the children younger than 10 years of age, minoxidil solution can be applied or topical corticosteroid can be considered first. Diethrenol cream can be used for the chronic stable hair loss that has previously failed to respond to corticosteroid, because diethrenol is also an irritant, so it's going to work in the same way, like creating the autoinflammatory process. So for this treatment or this topical treatment of alopecia areata, you can remember it's quite simple mnemonic. Most topical most best topical, you can just remember it, most best topical treatment. So most best topical treatment for alopecia areata is M for mometasone or methylprednisolone, T for triamcinolone, and P for your betamethasone. So these three are options for the alopecia areata most best topical treatment. Next comes 8-year-old boy is brought to your practice by the mother who is concerned about the patch of the hair loss. So again, there is a patch of the hair loss, not the whole of the diffuse hair loss on the scalp. According to the mother, hair fall started 2 weeks ago and left the area bald. So there was a bald area. On examination, there is a 2 into 3 centimeter area of the patch hair of the scalp. There is no scarring, no inflammation, flaking of the area. The region is completely bald with no hair. So again, it's alopecia areata, straightforward MCQ. This is the most same thing we have already discussed. Next, we are going to do this one. Which of the following statement is correct about the lipoma? Lipoma is a pre-malignant condition. No, it's always a benign condition. They are usually lobulated. No, lipomas cannot be tethered. Yeah, it's a lobulated thing. Lipoma cannot be tethered to the skin. Or lipomas occur on the scrotum. Lipomas are invariably subcutaneous. So we have to choose the correct option. So lipomas are usually lobulated. Lipomas are most commonly benign tumors of the mature fat cells that can be seen in any body side of the fatty tissue. They are not pre-malignant. They are benign. They are not pre-malignant. Although they frequently occur in a subcutaneous tissue, it is not uncommon to see in the deeper layers such as beneath the fascia or within the muscles. As there are little fat in the scrotum, lipoma almost never occurred there. So lipoma always occur on the fatty tissue. When there is no fat, there is no going to be lipoma or the fat deposition. Unlike lipoma, epidermoid cysts of the scrotum are common. So when there will be cystic swelling of the scrotum, this is more likely this is going to be epidermoid cyst, not the lipoma. Lipoma are usually freely mobile and they are not attached to the overlying skin. However, in the areas such as back of the neck and trunk, they can be less mobile and could be less immobile. The more characteristic of the feature of lipoma is it is a lobulated contour. L for lipoma, L for lobulated. So they are reliably differentiated from the epidermoid, which has a smooth contour, and epidermoid has a punctum also, which can be important for the differentiating from the different cyst. Next, a 50-year-old woman is presents to your clinic with a multiple lumps. So there are different lumps. She has lumps for the 20 years. The only complaint, apart from the concern about the look of the lumps, it's become painful at times. Not all the times they are painful at times. So it's an important clue. On examination, there are 30 mobile subcutaneous lump which feels soft, rubbery, lobulated. As we have already discussed, lipomas are the collection of fat. It can involve the subcut tissue and they are always lobulated. They are distributed bilaterally, upper and lower extremities, back and front. They mentioned that the mother has same problem. She is otherwise healthy. Which of the following is most likely diagnosis? So simply, there are multiple symmetrical subcutaneous lipoma. Another fat condition that is going to be painful is adiposis dolorosa. But the adiposis dolorosa is not lobulated. It's the feature of lipoma. So option A, adiposis dolorosa Dercum disease, is a syndrome characterized by the diffuse painful subcut swelling without the focal discrete lump. So it is important clue to understand the MCQ that if there is discrete lobulated mass, this is most likely subcut symmetrical lipomas. If it is not lobulated, it's a diffuse painful fatty enlargement. This is going to be adiposis dolorosa. Dolorosa is for pain and adiposis is for fat. So painful fat deposits is your adiposis dolorosa. Another important thing is epidermoid cyst. It contains the keratinized material. They are confined to the dermis and they are invariably attached to the overlying skin. We have already discussed lipoma is not attached to the overlying skin, but epidermoid cyst is attached to the overlying skin, that they are not mobile. They have a central punctum as discussed earlier and they become infected and form the abscesses. Like lipoma, epidermoid cysts do not predicate to the malignant condition, so it's always benign as well. Then is the neurofibroma. This is a very important disease. Neurofibromatosis NF1 is also known as von Recklinghausen disease. It is a disease of nerves which has a cafe au lait spots and the pedunculated neurofibromas, which is also known as molluscum fibrosum. Given the history characteristic, it's not neurofibroma. Next come the following photograph show the skin lesion of the 73-year-old woman who resides in the nursing home. So she does not take care of herself much. The lesions are very much itchy and she keeps scratching them, especially at night. So itchy lesion at night with a homeless man or the carefree lady. It's a very much important clue about the scabies. The itch prevents it from the good night sleep. On examination, she looks disheveled and poor care for. So it's important clue for scabies. Which of the following would be the most appropriate treatment? In the pictures, you can see the finger webs are involved. These are very typical sites for the scabies, and any flexures can be involved. In the webs, there are typical burrows of the scabies. So this is a straightforward MCQ, and the answer is topical permethrin 5% cream. Important point in the treatment of scabies is that you have to treat all the contacts of the scabies, whether they are presenting with the disease or not. If the patient from one house is affected, you have to treat the whole of the family member, because it's very contagious. The itching appearance of the lesion and the leaving in the nursing home all favors to the scabies as the most likely diagnosis. First line medication for the scabies is permethrin 5% cream. If the treatment with permethrin fails or the patient is sensitive to the drug, benzyl benzoate can be used as a second line treatment. Benzyl benzoate is more irritating to the skin and fail to inadequate adherence, so the permethrin is a good option. If patient don't respond to permethrin, the next option is going to be oral treatment, which is in the form of ivermectin. Next, option B, itraconazole is definitely not for fungus. Not for scabies, it's for fungus. And the topical corticosteroid moderate potency injunction with the permethrin benzyl benzoate will no effect on the scabies. Then the gamma benzene hexachloride, which is lindane, were formerly used for the treatment of scabies. It is no longer approved in Australia. In a bacterial infection, superimposed scabies antibiotic can be used. Mipiracin or oral ceflexin. More severe cases, erythromycin is not routinely used for the scabies. Next comes Ben, 10-year-old, is brought by his mother to the GP for the advice on melanoma screening. Which of the following puts Ben at the highest risk of developing melanoma? So for melanoma, there are very clear-cut guidelines and very extensive guidelines about the melanoma. So you have to remember all these. Any previous history of melanoma, any previous history, you are at 10% great risk of developing melanoma. Your own personal history of melanoma, 10% increased risk. But if there are multiple melanocytic nevi, which can be benign on your body, there are 7% increased risk of melanoma. So 2 points. Your previous history, 10%, and your multiple nevi on your body is 7%. Then is the multiple dysplastic nevi. There was benign nevi that were forming the 7%, but if you having dysplastic nevi, this is 6%. Then previous history of non-melanoma skin cancer. Previous history of melanoma was 10. So previous history of non-melanoma skin cancer is 4. So we are just putting down the risk. Family history of melanoma. Your own history of melanoma was 10. Your family history of melanoma is 2% increased risk. And then comes fair complexion. Fair complexion is also 2. And UV exposure is least risk factor for the melanoma, which is 1.5%. So this was very important. Melanoma is an important and very favorite topic for the exam point of view. For the MCQs, you have to remember all these things. So among the options, family history of melanoma in the first degree relative is the most preferred option. So this is all about the dermatology MCQ. Some of the MCQs are remaining.